Well, let me tell you about Dr. Howard Kim. He received his medical degree from Duke University, completed a clinical residency in emergency medicine at Denver Health Medical Center, and completed a research fellowship in health services and outcomes research at Northwestern. He currently practices emergency medicine at Northwestern University's Feinberg School of Medicine, where his research focuses on acute pain management, preventing and treating opioid use disorder, and the impact of marijuana legalization on emergency care. His work has been published in the New England Journal of Medicine, Annals of Emergency Medicine as well. So here, please welcome Howard Kim.
Can everyone hear me okay? I'm actually going to stand down here if that's all right. Thanks for inviting me out today to talk to you about some lessons we learned from our observations of marijuana legalization back in Colorado in 2012. And obviously there's a lot of relevance to what's going on in Illinois now. So just a brief introduction. I'm an emergency physician, and our mantra as emergency physicians is anyone, anything, anytime, which means that when we're in the emergency room, whatever comes through that door, we're there to help you with. We're ready, willing, and able. That means it could be something like a heart attack, stroke, or a stab wound, or it could be something not so serious like I can't get the ring off my finger, or my child stuck a bead inside of their nose, and they can't get it out. But very frequently we see a lot of intoxicated patients. Like when I worked on Friday night and Saturday night, we saw a lot of intoxicated patients. So that kind of makes me an expert on intoxication, and I guess that's why I'm here to talk to you today. I've given a version of this talk a few times to several different audiences, and it's always interesting to me. The number one question I get afterwards is, so are you for or are you against marijuana legalization? And it's always interesting to me because in my practice, in my everyday work, we don't even think about whether something is legal or illegal because it doesn't make a difference to our patients. That before marijuana was legal, we saw plenty of patients come in who smoked or used marijuana. After marijuana is legal, we still see patients who come in after using marijuana. So that sort of never factors into my decision making, never factors into my work. And so the reason I mention that is just to sort of frame today's discussion that the anecdotes, the data that I'm sharing with you is not in order to advance an agenda. I honestly don't even think about legalization in my day-to-day work. It's more just to present my experiences sort of on the front lines in the emergency room. The second hat I wear is that I'm a researcher, and my goals as a researcher are to improve public health and safety. Obviously, from my clinical work, I know that people will use marijuana regardless of whether it's legal or not, so let's just make sure that they use it safely, and let's find ways for people to use it more safely. And finally, I don't have any disclosures or financial conflicts of interest. I don't own any stocks in marijuana companies. I don't stand to gain from any position either for or against marijuana legalization, so I think that's important to say. So let's just talk about some of the terminology first. So what do we mean when we say marijuana? So marijuana is basically a common term synonym for cannabis, and cannabis refers to any product coming from the cannabis sativa plant, so sort of the well-known everyday strain of marijuana. The plant, that is to say the leaves, the flowers, the buds, they contain over 80 cannabinoids, and cannabinoids are chemicals that act on cannabinoid receptors throughout the human body, and so basically they can exert a number of effects. You probably have heard of delta-9 tetrahydrocannabinol, THC, and cannabidiol, CBD, in different products. Like you drive by, you see massage shops saying CBD-infused oils, things like that. That's what they're talking about. It's a cannabinoid that occurs in marijuana. This is the molecule for THC. I only mention this to say that throughout this talk, I'll be using the words marijuana, cannabis, and THC interchangeably. And although technically they don't mean the same thing, people use those terms just to refer to marijuana very generally. Why do we care about marijuana use? Well, it's the most commonly used drug in the United States. So this survey data is from 2016, a national survey. Basically asked the question, in the past month, have you used any illicit drugs? And 29 people responded yes in 2016. Of those 29 million people, 24 million said that they had used marijuana in the past month. So that's an astonishing majority of that 29 million Americans. There's been a lot of talk, and rightfully so, about the opioid epidemic, the opioid crisis in the United States, and Rightfully so, because people die from opioids that you overdose, and that's a big epidemic right now. But I only mention that to point out that look at these numbers for marijuana, 24 million compared to people misusing prescription pain relievers, 3 million, so about 8 times as much. On top of that, marijuana use is increasing. This green line here, so this is basically survey data from the same national survey, but over 12 years of time. The green line represents the percentage of adults in the United States reporting marijuana use. It increased from 10% in 2002 to 14% in 2014. The blue line represents the mean number of days in the last month that those adults have used marijuana. So in 2002, it was 10 days a month. In 2014, it was 16 days a month. And the purple line represents the perception that marijuana poses no risk of harm. And that was around 6% in 2002, and it's increased to 16% in 2014. So what this basically shows is more people are using marijuana. The people that are using marijuana are using it for more days, and more people are likely to use marijuana because perceptions of risk that marijuana is not harmful are increasing. And this is only data from 2014, so you can imagine these trends have only continued. On top of that, marijuana is becoming more potent. This data represents DEA seized marijuana samples over the last 2 decades, starting in 95 and going to 2012. The THC content, so that molecule we talked about, the cannabinoid, that is responsible for the psychoactive properties of marijuana, was about 4% content in 1995, and in 2012 it has nearly doubled or tripled to the 10 to 12% range. And again, that's only data up to 2012, and it's been 8 years since, so you can imagine that line is increasing. So the point is, this isn't the same type of marijuana that people were smoking when you were in college and I was in college. That was a long time ago, and now these strains are much more potent, that the content is much more potent, and we're seeing much more exaggerated effects. How is marijuana used? Well, this is data from the Colorado Department of Public Health in 2015. Basically, just to ask people, when you use marijuana in your sort of daily use, how do you use it? 75% responded that they smoke marijuana either as a blunt or a joint or in a pipe. 39% report that they vape marijuana, and 14% reported that they use edible marijuana products. Is everybody familiar with vaping? Do I need to go into that a little more? Yeah. Vaping is essentially, it's heating whatever product is put in the vape chamber. So that could be marijuana buds itself, or it could be a concentrated oil. It's heating it to the point where it boils, but it doesn't combust. So it doesn't light on fire like a cigarette does. And theoretically, you're able to release the THC from liquid to gas format so you can inhale it, but it doesn't cause a combustion reaction like your traditional burning something with smoke. The theory being that it's not as damaging to the lungs because there's not as much burnt product or smoke going into the lungs. But the one key point I would say about that is the sort of liquids or oils that are put into these vaping products, especially as it relates to marijuana and THC, can have a much higher THC concentration than a typical cigarette. Now, the mathematicians in the room are probably saying, well, these numbers don't add up. That's more than 100%. That's obviously because people use marijuana in more than one type of way. The political landscape surrounding legalization has progressed rapidly over the last few years. So this map was made in July of 2016. At that point, only 4 states had legalized recreational marijuana. So these states in the blue right here. The states in the green are medical marijuana legalization. So the first states to legalize marijuana were Colorado and Washington in 2012. Afterwards were Oregon and Alaska. And since that time, so just over 3 years, this many states have now legalized marijuana. So California, Nevada, Maine, Vermont, Massachusetts, Michigan, and the District of Columbia have all legalized marijuana, and then most recently Illinois has. Additionally, the number of states legalizing medical marijuana has increased considerably too. Utah, North Dakota, Missouri, Oklahoma, Arkansas, Louisiana, Florida, West Virginia. So this is only in 3 years' time, so not even one full presidential administration, and the map has changed that much. Other states that are already beginning to discuss marijuana legalization initiatives, New York, New Jersey, Ohio, those are probably the next states to come. So why do states legalize marijuana? Well, there's been a number of offered reasons. Well, number one, we know that there's disparate racial prosecution of marijuana-related crimes, right? We know that black Americans are almost 4 times as likely to be arrested for marijuana-related crimes than white Americans, despite similar prevalence of use. Others have stated that the war on drugs is a resource drain, so 50% of drug-related arrests are due to marijuana. Do we really need our police dollars, our police manpower to be dedicated to fighting what the public is increasingly seeing as a harmless drug? Right? And that's the third reason to legalize marijuana, because it aligns with public opinion. This is a poll of Illinois residents conducted in March of 2017. Obviously, this is right before marijuana was legalized here. The question asked a basic question: do you oppose or support a measure that would legalize recreational marijuana and regulate it and tax it similar to alcohol and tobacco? Well, 2 out of 3 Illinoisans said that they would support such a measure. And there's obviously a bigger split between urban and rural Illinoisans. The urban populace responded that 74% would support, while rural populations responded that about 54% would support. But that's pretty consistent with what we see the split between liberal and conservative policies. There are also a billion other reasons to legalize marijuana, like literally 1 billion. So since Colorado legalized recreational sales in 2014, they've generated $1.2 billion of tax revenue. So not just sales, tax revenue for the state. And that comes with about $7 billion of total sales of marijuana. It's pretty easy to see why this source of potential tax revenue would be attractive to a state like Illinois, which is frequently running in the red. So let's just look at what the potential tax gains would be for Illinois from marijuana taxes. We have the standard sin tax, right? So that could be anywhere between 10 to 25% based off the THC content of the product. Let's just assume it's 25%. There's also the sales tax that we pay, 10.25% for me in the city of Chicago, on standard items like groceries. And then the Illinois legislature allowed the option of municipalities to add on an additional 3% tax, which you know the city of Chicago and Cook County decided to take part in, so that'll kick in July 1st. And when it comes down to it, so the total tax you would expect to pay on a marijuana product is 41%, incredibly high. That's not even mentioning the 7% gross receipts tax. So that's a tax that's paid on the product when it's passed on from the cultivator, the person who grows the marijuana, to the distributor. And of course, the consumer doesn't see this tax as a line item on their sales receipt, but you bet it's going to be baked into the cost. So just to talk about the Illinois legislation specifically, the details. So Illinois was actually the first state to legalize marijuana by the legislature. The other states that have legalized marijuana to date have done so with a referendum. But the Illinois legislation states specifically that you have to be age 21 or over to use marijuana, use or possess. That makes sense. And the actual purchase possession limits are that if you have a marijuana plant, like the dried buds, you can have up to 30 grams, which is around an ounce. If you have edible products, they can contain up to 500 milligrams of THC. Or if you have cannabis concentrate products, like what you would put in a vape pen, you can have up to 5 grams of it. The possession limits for non-residents is half that amount. It also states that there's no public consumption, right? It's just like open container laws. You can't walk around drinking a beer in public, or that you can't drink in a moving vehicle. The legal limit is established at 5 nanograms per milliliter, and there's no personal growing allowed, so you're not allowed to grow your own plants in your house unless you have a medical marijuana permit. So now I want to briefly talk about some of the lessons we learned from legalizing marijuana in Colorado. So in Colorado, initially marijuana was legalized in 2012. That means possessing and using, but sales weren't legalized until 2014. I think initially when marijuana was legalized in Colorado, we didn't know a lot about the best ways to inform the public or protect the public, or even what sort of harms the public would encounter from going from not having recreational marijuana legalized to having recreational marijuana legalized. The first major lesson we learned is that members of the public, especially those that are naive to marijuana, really underestimated the effect of edible products. Here's an example right here. They can be baked into anything, cookies, brownies. And that's because there's a delayed onset of action in edible products. When you smoke marijuana, this is lab data from healthy volunteers, the peak effect here is probably within 3 to 5 minutes, so really quick. Makes sense. You smoke something, it immediately goes into your lungs, it gets absorbed into the bloodstream, and it goes to the brain quickly, and you feel the effect immediately. The problem with eating something is it basically needs to be digested, and the peak effect takes much longer. We basically, this data basically shows that the peak effect of marijuana after ingesting it is around the 2 to 3 hour mark. So we go from 3 to 5 minutes for smoking to 2 to 3 hours for ingesting. What basically happens is that the person who eats or buys an edible marijuana product for the first time eats it and says, maybe 15, 20 minutes later, I don't feel anything. This isn't what people describe to me. This isn't what the movies say it's like. I just feel like myself. I must have gotten a dud, right? Maybe they didn't mix it properly. Maybe they cooked it at too high of a temperature and there's no THC left in it. So what do? They have another marijuana cookie, right? So they eat their second marijuana cookie at, say, minute 30, minute 45. And again, they wait a little bit and say, I still don't really feel anything. I'm starting to feel a little bit of a buzz, but I must be really good at this marijuana thing because I'm totally myself and I feel completely sober. So what do? They eat a third marijuana cookie, right? So by the time they finish the third cookie, now they're starting to feel the effect from the first cookie because we're at like an hour and a half, and there's still 2 more cookies on the way that are being digested in their gut. And that's the basic problem. On top of that, initially when marijuana was legalized in Colorado, there's very confusing and inconsistent dosing. So the individual dose of THC for one person is, or one serving size is 10 milligrams of THC, right? 10 milligrams of THC. But what does the everyday person, what do you and I do when we go to the store and you buy a cookie? You eat the cookie, right? This cookie contains 100 milligrams of THC, so 10 servings. It does not make normal human sense to buy a cookie, cut it into tens, and eat a tenth of it, right? You buy a cookie, you eat a cookie, right? But in this case, you eat the cookie, and it's 100 milligrams, it's 10 serving sizes. And in that previous example I told you about, you eat 3 cookies, now you've had 30 servings worth of marijuana. So as a result of sort of increased high publicity cases of visitors coming to Colorado, eating edible products, and having bad experiences, Colorado introduced these new regulations that require dosing at 10 milligram portions, right? So now each individual serving size must be individually demarcated so the consumer can understand, and also has to contain the universal stamp for 1 serving of THC. The second trend we started to see was that we had a lot of out-of-town visitors come into Colorado sort of for the marijuana experience, right? Like I said before, Colorado, Washington were the first states to do so. This is basically our version of going to the Netherlands and smoking marijuana there. It's much cheaper to travel domestically to sample marijuana. We observed that after marijuana legalization in 2012, we saw a big spike in the number of out-of-state residents coming into the ER for marijuana-related complaints. Obviously, we saw an increase in Colorado residents too over time, but that was more of a smooth, steady trend over time. But the out-of-state resident trend clearly spiked up after 2012 and diverged. Initially, we were seeing a lot of patients come in strictly for this marijuana tourism that I talked about, that they came in to see what it was about, they wanted to try it. That was the explicit purpose of their travel. This is a picture I took at a marijuana dispensary in Colorado, or in Denver, downtown Denver, right after marijuana legalization. Just one of those maps where you go up and you put a push pin where you're from. You can see here, people are from all over parts of the world, from Europe, Hawaii, Australia, Asia, South Africa, traveled basically everywhere to come to Denver, Colorado to see what the marijuana experience was about. But I think sort of after that initial novelty effect died off, what we saw more of was this trend of a when in Rome effect. And that means like people that are traveling to Denver or now Chicago for other reasons. You're there for a wedding, you're there for a business trip for work, you're there for a professional conference. This is the American College of Emergency Physicians, our annual professional conference that took place in Denver in 2019. Basically 30,000 emergency physicians descending upon one city. And if any of you live in downtown Chicago, you know the phenomenon where anytime there's a big convention, I think there's like a candy and confectioners candy maker convention every year at McCormick. There's, hotel conventions. Basically any industry you can think of brings a broad group of people in that they say, you know what, when I'm in Chicago, as long as I'm there, marijuana is legal there. It's not legal where I'm from in Arkansas. I should try it there. So we see a lot of people come in that say, I'm here, I might as well give it a try. So what do we see when people use marijuana? What are the clinical effects? Well, when used at therapeutic doses, people feel euphoria, right? They feel a high. they feel groovy, they feel mellow, maybe they have increased appetite. That's sort of what people are aiming for when they use marijuana. But when they use marijuana in excess, we start to see reasons why they come into the emergency room. They could develop cardiovascular symptoms, like they have a fast heart rate, may have chest pain, may feel like their heart is beating out of their chest. A lot of people get GI symptoms, so basically nausea, vomiting. And then some people can get neuropsychiatric symptoms, especially in high doses. So that's either really high anxiety, or it could be something like acute psychosis, where they're acting completely not like their self, they're altered. In one particularly memorable example in Denver, we had a gentleman come in overnight in the emergency room who was found running around downtown Denver naked, just with shoes on. Running around, just yelling, screaming nonsense. Same thing when he came into the emergency department, completely naked, not making any sense, just speaking sort of gibberish. Eventually, the next morning when he woke up, I went to talk to him and said, "Do you remember what happened? What brought you to the emergency room here?" And he said, "I have no idea what happened. Where is my suit? I'm here for a business meeting. I'm from out of town," right? So he went to go try some marijuana because he was here. He finished his meeting, had some edible products, and then doesn't remember much after that. Now, these are definitely in the minority. I'm not here to say that if you use marijuana, you're going to end up running around downtown naked. I only mean to say that when used in excess, there are possible side effects, adverse effects, as is the case with any drug, right? Alcohol, tobacco, anything you take, if used in excess, you could have a bad reaction to it. The third trend we started to see was pediatric exposure. So this is basically kids getting into parents' marijuana stashes and eating them. And it's pretty easy to see why kids got into the marijuana because they were packaged as these sort of bright, colorful, candy-like edibles, right? So these are high-chew edibles. These look identical to Sour Patch Kids, right? What kid would not see this on the table, reach up, grab it, and try to eat it? This data is from 2009 to 2015 in Colorado. Basically, this line up here represents the number of calls to the Poison Control Center in Colorado saying, "What do I do? My kid got into an edible." These data down here are national data. So you can see here the Colorado data far exceeded the national data in terms of calls to the Poison Control Center for marijuana-related ingestions in kids. This is the same data, but just shows basically hospital visits to a single children's hospital in Aurora, Colorado. Similarly, I think what we're seeing now more in Illinois is the same trend of exposure by grandparents, parents, housekeepers. So what I've seen a couple times now in the emergency room is grandma, grandpa, comes down from upstairs and they see that their 16-year-old kid, their 18-year-old kid has baked some brownies. Like what a nice surprise. They never do anything, they never do the dishes, they never help make dinner, but they've made brownies, so I think I'll have one. So they have the brownie, and then all of a sudden they are overcome with anxiety, they're sweating, their heart is racing, they're vomiting, and they can't figure out why. They got into their child or their grandchild's marijuana stash. The other thing is, everyday housekeepers, things like that, are cleaning somebody's house, cleaning their employer's house, and they come across candy that looks like this. And they help themselves to it, and they come in with the same thing. They're not sure what's happening. All of a sudden, the ambulance is called, they showed up, and the housekeeper was at this house just totally freaking out, saying she's going to die, clutching her chest. Turns out she got into her employer's chocolate marijuana stash. The fourth trend we saw was an interesting phenomenon that physicians are now observing called cannabinoid hyperemesis syndrome, which is basically daily users of marijuana can paradoxically develop this syndrome where they have these intractable nausea, vomiting episodes, and abdominal pain. So they come in completely uncomfortable, writhing, grabbing their belly, and just nonstop vomiting everywhere. And basically, we started to observe this trend that's characterized by these features, where people come in, the vomiting sounds very stereotypical, it's very loud, very retching. They report that this has been going on for a long time. They've tried everything. Maybe they've seen multiple other doctors and they can't get it under control. They use marijuana every day, and they all almost to a T say that the only thing that helps with this is if I take a hot shower or I get in a hot bath. In fact, I've had patients in the ER tell me, "Do you have a bathtub here in the emergency room? Because that's all I need. I just need a warm bathtub." Not a normal thing to ask for a bathtub in the emergency room. Just like you don't want to be in a bathtub. If we had one in the emergency room, it would have all sorts of shared germs in it. But sort of just a stereotypical feature where people say, "I'm only relieved by hot showers or hot bathing." And the only thing that really helps, I think, in the long term for patients that develop this cannabinoid hyperemesis syndrome is stopping marijuana. which is very difficult to do because I think the prevailing belief is that marijuana is supposed to help nausea vomiting, that's supposed to stimulate anorexia. And while that's true, we see this sort of paradoxical reaction in habitual cannabis use. So it's basically people that have used every day for many years, and the only thing that really will ever get it to stop is stopping marijuana, which is a tough thing to convince these patients to do. In Colorado, we observed that visits for this type of cyclic vomiting doubled after medical marijuana legalization. That we initially saw 36 per 100,000 ED visits. After legalization, we saw 67 per 100,000 visits. The thing I want to emphasize is the overall burden remains low. So we're not talking about an epidemic that's completely overwhelming emergency rooms so that every person that uses marijuana is going to run into this. In fact, it's a very small number overall. I'm just telling you that it exists and it's something that we've been observing. I'd say it's similar to, many of you may have heard now with the increase in popularity of online gaming that they have they've diagnosed online gaming as an addiction, and you can check into online gaming addiction centers. I would say the same thing as that. You wouldn't say that we have an epidemic of online gaming addiction and that all our school-age children are now non-productive members of society. It's just a thing that happens that we've been observing. The fifth and final observation is that drug testing has really been murky waters. The problem with drug testing for THC is that it's a highly lipophilic molecule, which basically means it's fat-soluble and not water-soluble like alcohol. Alcohol is water-soluble. Water-soluble molecules are very predictable in terms of when they'll be eliminated from the body. Fat-soluble molecules are basically taken up by all the fat cells in your body and stay there for a long time. And so your urine drug test will be positive for a very long time. So if you smoked marijuana today, right after this talk, your urine drug test might still be positive on Friday. And obviously, you wouldn't still be feeling the effects from smoking marijuana on a Sunday, but your urine drug test would be positive. And that's a very tough thing to reconcile because clinically, you're not intoxicated. Clinically, you used marijuana a week ago and there's no effect now, but your urine drug test is positive. And this could be problematic if you're getting routine drug testing for work or a new job or something like that. This data is from volunteers of 11 volunteers who used marijuana on a daily basis. In this experiment, they basically put them in a facility where they monitored them for a month. And the point of putting them in that facility was to make sure that they didn't leave and have access to marijuana. So they wanted to control the fact that they didn't use any new marijuana. They then tested over the course of 30 days whether these 11 subjects continued to have positive urine drug screens. And by 26 days, only one patient had a negative urine drug screen. These are chronic users of marijuana, so these are people that use every day. It's not the same as just using one time, but it's a point that bears repeating, that the urine drug test will be positive for a long time because marijuana or THC is taken up into the fat cells of your body. On top of that, there's really no uniform definition of what THC level is equivalent to intoxication. In Colorado and in Illinois, the limit is 5 nanograms per milliliter. But in a state like California, it's just a clinical exam. So if a police officer pulls you over and they suspect that you're intoxicated, like they do the standard drunk test where you put the heel to the toes, and you can't do it for whatever reason. In my line of work, I tell our ER physicians, maybe you just worked a 24-hour shift in the emergency room, and yeah, I can't walk in a straight line after that. But if your urine drug test is positive from using marijuana a week ago, say when you were visiting a friend for a wedding in a marijuana legal state, that's going to be problematic. You have a positive urine drug test, the police officer says you're intoxicated, and the standard in California is that it's a clinical exam. Drug testing in the workplace is also very complex, even more complex. The problem is that marijuana remains illegal under federal law. So the Controlled Substance Act of 1970 says that marijuana is a Schedule I substance. That means it has no medical value and that it's a high risk for abuse. But we have individual states that are legalizing marijuana. So what do we do with that tension? Illinois, Colorado, California say marijuana is legal, but the federal government says it's illegal. Well, right now it's not a huge area of contention because the Attorney General is choosing not to sort of prosecute this distinction, but it can be a problem if that conflict is ever raised in case law. And if you think back to your high school civics day, there's a supremacy clause which says when federal and state law are in conflict, the federal law always wins. This came up in a famous Colorado Supreme Court in 2015 called Coates v. Dish Network. An employee named Coates was fired after he received a random urine drug test that was positive for THC. he sued Dish Network under the Colorado Lawful Activity Statute, which says it's unfair employment practice to terminate me because I'm engaging in lawful activity off the premises of the employer during non-working hours. So, makes sense, right? He had a random drug test that was positive. He said, well, I used marijuana not while I was at work, not while I was on the job, and you terminated me, and that's not right. The law says that's not right. On top of that, Coates had actually disclosed to Dish Network when he was hired that he had a medical marijuana permit and that he was using medical marijuana. But they didn't care about that. They fired him, and he sued them and brought it before the Colorado Supreme Court. Colorado Supreme Court basically ruled that the term lawful only refers to those activities that are lawful under both state and federal law. And because marijuana remains illegal under federal law, they ruled that Dish Network was within their purview to terminate him for a random urine drug test that was positive for THC. So we don't have a lot of these examples. Right now the case law is still developing, but legalization is complex because of this federal-state conflict. So it's very much an evolving area, and we don't really know where this is going to go. So I always counsel people, in terms of using marijuana, possessing marijuana, it's legal in the state of Illinois, but if for whatever reason you get randomly drug tested at your workplace or you're applying for a new job, you may run into a tricky situation where it'll be tough to justify what happened. And it also bears the point that even though marijuana is legal, it may not necessarily be legal in all sense of the word due to the federal law that says that it's a Class 1 substance. So finally, I just want to leave you with a little bit of content on how to interpret all the different evidence in the headlines that seem to come out almost weekly that offer conflicting perspectives on whether marijuana is helpful or harmful. So now we've moved on from the prior discussion of this was our experience legalizing marijuana, how we could have done it better, how we could have approached labeling, public education better to decrease public harm in Colorado. Now we're just talking about the science of whether marijuana is actually harmful or whether it's actually helpful. Almost weekly, it seems like we see headlines like this: 10 ways medical marijuana can be used to treat disease. Can marijuana help cure the opioid crisis? Well, a new study throws cold water on hopes that more liberal cannabis policies could stem the opioid epidemic. Well, can cannabis treat epileptic seizures? New evidence suggests that marijuana may be an effective treatment for patients with drug-resistant epilepsy. Yeah, but smoking super-strength cannabis can trigger deadly seizures, says new research. So how do you reconcile all this conflicting evidence and walk away with something that would be useful from this talk? So rather than go through every single study that's been published throughout time on marijuana, I just want to provide you with some brief areas that I feel like the evidence is strongest for benefits and harms of marijuana. So let's begin with evidence of harm. Well, we know that marijuana, the reason people use it is so you get a high. So you feel groovy, so you feel mellow. We know this causes impaired motor coordination, it interferes with driving skills, and increases the risk of injuries, right? So we know that you shouldn't use marijuana under the influence. So we know that the government should establish some sort of standard that says you can't be intoxicated just like alcohol. That's probably best for the public good and public safety. We also know that young developing minds exposed to marijuana don't do well, that it alters brain development. So let's let the American College of Obstetrics and Gynecologists and the American Academy of Pediatrics and the Surgeon General to recommend that women who are pregnant and breastfeeding don't use marijuana because you don't want to expose the developing brain to marijuana, and also has been shown maybe to result in low birth weights. We also know that marijuana use, especially early in adolescence, is correlated with poor outcomes like dropping out of school, lower IQ, diminished life satisfaction and achievement. And adolescents, because of their developing brain, shouldn't be exposed to marijuana or use marijuana. And that's obviously the reason why there's an age limit on marijuana in every state that's legalized it. In terms of potential benefit, we've all heard that marijuana can be used is helpful in glaucoma. We've heard that it can help with nausea and vomiting in chemotherapy, that it could help stimulate appetite, help stimulate weight gain in chemotherapy in patients with cancer and patients with AIDS wasting syndrome. We've also heard that marijuana can be useful in chronic pain, and that's because it acts on cannabinoid receptors in the human body and helps mediate pain effects. It can also be used for muscle spasticity and multiple sclerosis, and in a rare subset of pediatric patients with seizure disorders that are resistant to traditional anti-epileptic drugs, a strain of marijuana has been shown to be effective in that. I will say that all this evidence sort of supporting potential benefit is very preliminary or early at this stage, and that's because marijuana is still a Schedule I drug classified by the federal government, that it's deemed not to have a medical benefit. You basically have to get all sorts of special permits, investigational drug applications, to study application. to study potential benefits of marijuana. And that's why it's tough to definitively say that things will definitely be beneficial in this area, but at least preliminary evidence is best for these areas here. So that's it for the content of the talk. I'm happy to take some questions. I think maybe we'll have a little bit of music, and then we'll do the Q&A session afterwards. Yeah. Thanks.
Could you comment on coronary artery disease problems from smoking marijuana?
Yeah, I think right now there's the evidence is not firm that there is an increased risk of cardiovascular disease. I think there's sort of two different categories. One is the acute risk, and initially there were like case reports or news headlines that say, you know, this person smoking marijuana got a heart attack. I don't think that there's any scientific evidence that smoking marijuana sort of, you know, in that exact moment is going to give you a heart attack. And sort of chronic risk with using marijuana, there's also not great data that using marijuana for many years contributes to cardiovascular disease. We think that it may contribute to rates of lung cancer, but we're not actually sure because, again, we just have observational work, and people more likely to smoke marijuana also are more likely to smoke cigarettes. But I would say scientifically it may make sense that it's not as harmful as cigarettes because, again, there's not as harmful of products inside of it, especially with vaping maybe. But anytime that you take something and light it on fire and combust it and breathe it into your lungs, it's going to have some effect on the body. So I feel like if you want to maintain good cardiovascular health, if you don't want to develop emphysema or chronic bronchitis, it's probably best not to smoke marijuana. But right now, I can't say that we have slam dunk evidence that it contributes to a risk of lung cancer or cardiovascular outcomes.
Hello. My background is more in public health, and I'm wondering if any of the states that have legalized this a number of years ago started looking at the overall cost, like the additional ED visits and the additional car accidents and the amount of police effort needed to do that, the extra court cases if you sue over losing your job for a positive. You know, if you add that up, maybe it's more than the $1.2 million that the state of Colorado got in tax revenue. Maybe they're spending $2 million on additional X, Y, or Z.
I don't think anybody's ever done a cost analysis. We've certainly looked at the ED visit data, like the graph I showed you has been increasing. There's another, so this graph here shows rates of fatal MVCs after marijuana legalization in Colorado. So this line, the dark line is Colorado, and this dotted line is similar states in terms of demographic makeup of Colorado, but not Colorado. Basically saw an increase in the percentage of drivers that had tested positive for marijuana after legalization. So I think there's some indication that there are more car accidents. I don't think anyone's ever done a cost analysis, but you're right. I think societally, you think about the tax revenue, but you also have to think about, you know, like you were saying, things tied up in litigation, motor vehicle accidents, et cetera, and any lost productivity from that. Again, I will say this research is also limited because we just have to go based off our observations and not a true experimental design. So this data basically shows the percentage of drivers who had marijuana in their system. It doesn't say that the marijuana definitely caused the accident. There's no way to prove that retrospectively, especially if the patient died. But it does show that the number of drivers who are on the road with marijuana in their system is increasing. And we know that the whole point of using marijuana is to feel euphoria, to feel high. Probably not best for driving. So it makes sense that there are more motor vehicle accidents, which is to be expected too. So anytime any new technology or substance is introduced, we'll see more effects of that. For example, motorized scooters, those are now becoming more prolific in Chicago. We expect to see more accidents, people hitting their head, people breaking their wrists from falling off motorized scooters, which we have.
Hi, do you have any thoughts on why some people really seem to enjoy marijuana and others it just makes them uncomfortable and anxious? Are some people wired differently, or is it different personality types? I don't know if you have any thoughts on that.
Yeah, it's an interesting question. I don't have any data to drive any thoughts on that. I think my observations are that it's probably a little bit of both. That some people just aren't the type who really enjoys using substances or using something mood altering. For example, you've probably met people who don't drink coffee, or they don't like the effect of caffeine on their system. And for most of us, it's like, that's insane. How do you function without coffee? But they're like, I just don't drink coffee. I don't like caffeine. It makes my heart race. So different people have different preferences. But I will say also that I think genetics plays a large part in everything. And there may be a component where someone's makeup, their lineage, makes them more likely to favor one drug over another. I will say that one evidence of harm that I didn't mention here is that in people with either a personal history or a family history of mental health disorders, so like bipolar disorder or schizophrenia, I think there actually is a very strong risk that using marijuana can sort of uncover those latent factors, or if you have bipolar that's well controlled on medication, it can sort of undo the effect of the medication and really worsen those effects. But I think, like a lot of things we observe in medicine, there's both a genetic and an environment component to it.
Was there an impact in the number of cases you saw coming into the emergency room for other drugs? Was there kind of evidence of, I grew up in the DARE gateway drug rhetoric era, signs of that, or signs of displacing other drugs because now this is a legal option?
Yeah, I would say the ED visits we saw at least were isolated marijuana use. It's very common to drink alcohol and use marijuana, so that's the one exception. But it's very common to drink alcohol plus whatever drug someone comes in with. So, someone comes in with cocaine intoxication or they did shrooms, it's not surprising to also find their blood alcohol levels elevated. So we did see that. But I wouldn't say we always saw marijuana with cocaine or we always saw marijuana with LSD. And there isn't a combination I know, like, for example, speedball is a combination that people use on the streets. It's heroin plus cocaine. That's a known drug that people use together. There aren't any sort of street formulations that I know of that use marijuana plus another drug. In terms of whether marijuana is truly a gateway drug, I don't know. The people seem to suggest that it is. There are studies that come out that say that it is. But again, the problem with those studies is that somebody who's more likely to use marijuana is also more likely to use drugs in general. So is it really that the marijuana sort of was the one thing that they needed to sort of break the seal to open their eyes to other drugs? I don't know if we can definitively say that. I can say that I've met plenty of patients who use marijuana and only use marijuana too. So I don't really know is the answer. In terms of whether it's displaced other drugs, perhaps the most interesting question would be about opioid use disorder and whether patients are really getting off opioids with it. That's also tough to say because in general, opioid use is declining because of all the different interventions over the last few years. Opiate prescribing is declining. So every study that comes out basically says since the state legalized marijuana, opiate prescribing is down, opiate overdose are down. But they're ignoring all the other secular trends that are happening in the background as well. Like, we've decreased our opiate prescribing in Northwestern, for example. It used to be like 18% of patients left with an opiate prescription. Now it's down to like 5%. And that had nothing to do with marijuana legalization. That was greater awareness of this opiate epidemic. It was greater attention and efforts to using other things besides opioids for pain. And we've also introduced like take-home naloxone kits where patients with overdose go home with naloxone to reverse an overdose. They get engaged with treatment. All of that factors into the background. So I think these observational studies that say since marijuana has been legalized, opioid overdose deaths have gone down. It's not as simple as that, unfortunately. But in terms of whether there's plausibility as to whether marijuana could just replace opioid use, I think it could probably help a little bit, but I don't think it's like a massive major solution that's just going to enable people to use marijuana instead of opioids for pain, basically. It may help an incremental portion, but it's not an easy sort of one pill that'll fix it all.
Hi. Do you know if the Illinois law, the way it was crafted, did it take into account some of the lessons learned in Colorado, like particularly the dosing of edibles and the packaging?
Yeah, as far as I can tell, there haven't been the same standards applied to Illinois law here. But nobody asked for my input when creating the law, so. But this is why I do these talks, to educate consumers, and this is what I tell my patients when I see them. Even if it's for non-marijuana related complaints, the one thing with edibles is just please be careful. Take one and then wait. You got to wait like 90 minutes, 2 hours. Just wait before you take another one.
Hi, I'm particularly interested in adolescents, being a mom of teenagers. When you compare like the use of alcohol versus marijuana, I'm sure neither are good for any brain, but what do we know about the effects on an adolescent brain?
Yeah, I think the evidence for long-term effects of marijuana in adolescents is stronger than for alcohol. I think that there is a strong belief that marijuana sort of interferes with the development in terms of goals, being driven, attendance in school, things like that. And additionally, I think that because marijuana is a psychoactive drug that's a lot different than alcohol, which doesn't result in things like psychosis, that it could potentially even contribute to developing things like bipolar disorder or schizophrenia later in life. So I think it would really be best for adolescents to avoid using marijuana. The problem is adolescents have been using marijuana for centuries. But I think now that marijuana is legalized and rapidly available, we just need to do a good job. I think probably targeting advertisements driven towards adolescents in terms of marijuana use and marijuana products, and just making sure to limit accessibility. I think we have to do the best we can, but I think you're absolutely right. Like, teenagers have no problem accessing substances, and they have done so for a long time. Probably both aren't good, but I think the evidence is probably stronger for marijuana that it could be more harmful.
Thank you for your talk. You mentioned that the potency of marijuana has dramatically increased, and I'm wondering why that is.
I think that's a good question. I don't know the answer for sure, but I would guess that people have gotten much better at cultivating strains. That just like people have gotten much better at microbrews over the last couple decades and have gotten it down to sort of an exact science, and this is the exact yeast that I use, etc. I think people are just getting better at cultivating strains. And sort of the natural tendency is for a product to be improved over time and not for it to degrade and for the potency to go down.
Thanks. You mentioned the 10 milligrams is kind of a typical dose. Could you talk a little bit about how much most people take when they take it, either for pain management or for recreation? And then are there certain levels that you tend to see when people are more likely to be coming to the emergency room for various things? Or obviously everybody's different, but...
Yeah, I would really say everybody's different. I don't honestly know that anyone has characterized dose, and I think the problem lies in the data I showed before, where the dose doesn't really correlate with their clinical symptoms, that our ability to test for marijuana is severely limited because it continues to exist in the body's fat cells, and we have no way of saying, well, you're acting like this, or you definitely came into the emergency department because your level is this much. It's just totally unpredictable. But I don't actually know how much people smoke or drink, or smoke or eat, that causes them to come into the ED, or what the typical dose is.
Thank you. Great program. Being a victim of too large of a cookie and getting a thing that said gummy and it not being gummy bears, is there a home remedy besides before you go into the ER?
No, I mean, I'll say basically what we do for you in the emergency room is we monitor you, we give you IV fluids, we give you, if you have primarily vomiting, we give you medicines for the vomiting. If you have primarily, feels like your heart's beating out of your chest, you have this feeling of impending doom, we give you medicines like Ativan, which is basically like Xanax. And so we just treat it symptomatically. There's no antidote that we grab that completely reverses everything. So I would say general advice is if you feel like you're doing okay, that it's not terrible, and that you can manage at home just with sort of bed rest and fluids, it's okay to stay home. If anything feels wrong, obviously come to the emergency room. We're always happy to see you. We would make you feel better. We would support you. The one exception being children. So if a child is exposed to marijuana, I don't think you should just observe them at home. You should probably call the Poison Control Center, because children tend to have different effects than adults. They tend to get a lot more somnolent and sleepy, and their breathing decreases, and that can obviously be much more serious. In a couple cases in Colorado, children had to be admitted. One of them had to be on a breathing machine. So in children specifically, the response is a little different, and I think if your child gets into marijuana, you should not try to stay home, basically. You should seek medical advice. But it's very, very common for people to get into marijuana that they didn't realize was an edible product, like the brownie example I said before.
So thank you for a very informative talk. I was just curious about the issue of testing. So you said it was, I think, 5 nanograms per milliliter. Is that, so I'm wondering, where did that originate before it went into the law? Is that blood? Is that urine?
It's blood.
If you've got any idea for better ways to test. And obviously the big concern I have is I guess overzealous law enforcement prosecuting people that are, no harm to the public, but they're, come back with a positive test.
Yeah, and that's what I worry about too. It's not based in anything that I know is a rigid, fact-based, this is the cutoff that we know. But it's the same thing for alcohol, I would say, that there has to be some threshold at which we say, okay, this is impaired and this is not impaired. You can imagine that some people with an alcohol level of, so what's the legal limit here, 70 or 80? Some people with a limit of with an alcohol level of 125 may be more sober than someone with an alcohol level of 50. But the government feels like they have to set a line somewhere. But the problem with marijuana, just as you're saying, is that the THC levels don't necessarily correlate with how impaired you are, and they can be positive for a long time. So it's a big issue of controversy right now in the medical and law enforcement community. There's not a good test that we can even perform, like a breathalyzer that tells you immediately what someone's blood alcohol concentration is. It's a big problem, and that's what I worry about going forward.
More questions? Oh, here we go.
This is another more legal than medical one, but I always wondered when somebody, if they're stopped by the police and marijuana is found, how do they prove that they bought it legally rather than illegally? Because with a 42% tax rate, there's still going to be a black market probably for it. So how do you prove that it's legal?
Yeah, that's an interesting point. I guess with a receipt, but I guess it's the same way for everything. It'll be whether the police choose to enforce that standard or not, because a police may see a dog in your vehicle, and by law you have to have the dog registered. But most police don't enforce that type of thing, and it would be very unusual to do so. But it's technically on the books. It's just really unheard of to enforce something like that. So I think it all depends on what the police choose to enforce. But I suppose hypothetically, they could say, did you obtain this illegally? Or it would be hard to say. But I guess sales receipts would be the way to do it. Yeah. Mm.
Yeah, I just wanted to know what the latest estimates for risk of psychosis are, or the incidence or prevalence.
Oh, I don't know those off the top of my head, I'm afraid. Maybe something I could provide for you later. If you're really interested, I could look into it. I don't know them off the top of my head.
So, I've been a medical marijuana user for a couple of years, and my preferred way of getting my marijuana until recently was through vapes. For a reason you said that with the edibles, you have to wait, and it's tricky to know how much to take. So when we found out that vaping wasn't good for you, I threw all my vapes away. And then I was talking to the owner of the dispensary in Evanston where I go, and he was like, oh, our vapes are safe. It's only the vapes on the street that are, dangerous. But, I really didn't believe him. But my question is, now that we know that vaping, is dangerous, why are the dispensaries who are, who were previously selling marijuana as a drug for medical use, why were they allowed to continue to sell the vapes, and why are they allowed to continue to sell the vapes now?
Are you talking about the recent press about people being hospitalized for vaping lung injury? So the recent news about that is actually a different isolated topic and doesn't apply to vaping in general. It applies to a specific contaminant that was identified in vaping liquids that were bought off the black market. Basically, those samples were contaminated, likely now with, we know to be vitamin E oils, that basically, for whatever reason, when they enter the lung, they cause lung injury, and these patients developed respiratory failure. They had to be on ventilators. But that was specifically with this contaminant found in the black market supply of this. So I'll say, in general, I don't think I would go so far as to say vaping is dangerous. It's dangerous in the sense that introducing anything into your lungs is probably not as good as introducing nothing. But in terms of all the recent news and attention that's been paid to people hospitalized for these vaping lung injuries, that's not vaping in general. That's the specific contaminant that was identified in black market vaping solutions. So I would say it's okay if you use medical marijuana via vape. It would be okay to continue that.
Oh, too bad.
Yeah, and then there's been other attention, like because the vaping pens contain batteries, sometimes those explode and cause other problems. So sometimes there's news articles about that. But there was a problem with the Samsung phones a year ago too, where the batteries were exploding, and one exploded on a plane and caused a fire.
What did Colorado spend $1 billion additional tax revenue on? I mean,
that's a great question. You'd have to ask the Denver Mafia what they did with it. I don't know. Yeah, it's hard to say. There's a brand new train to the airport. Who knows?
I know one of the tensions between the federal and state is that you can't basically get a bank to handle your marijuana receipts. What's the marijuana industry's biggest agenda right now to try to?
Oh, that's a great question. I don't know about that banking question. So
because federal crime to deal with marijuana. Basically, if you've got a business and you want to deposit your money, the know your customer laws for a bank would say that you can't take the money. So basically, it's a cash business.
Yeah, that seems problematic, especially if there's a lot of cash being exchanged and if you have to report or give tax revenue to the state. I don't actually know about that. I don't have any contacts inside of the marijuana business, so I don't know what their biggest agenda is at this point. My guess would be increasing legality so that their market is bigger would be my guess, but I don't know for sure.
Have you observed any of the effects of synthetic use of marijuana?
Yeah, so synthetic marijuana is basically, for those that don't know, the cannabinoids that I mentioned. The marijuana plant contains over 80 natural cannabinoids. You can also make any chemical in a laboratory, and so people make synthetic cannabinoids in the lab and used to sell them before marijuana was legalized. They used to advertise them as bath salts, but clearly they're not made for bathing. People would take them and smoke them. That was it was a much bigger trend, I would say, maybe like 5, 6, 7 years ago. And very stereotypically, you would get a lot of psychosis then, people smoking those products, because when you create it in a lab, the potency is much higher, the effect is really unpredictable, but we'd see a lot more people coming in agitated, altered, screaming, had to be restrained. But that was a bigger trend, I would say, 3, 5, 7 years ago, and now that marijuana is legal, people have turned more to legalized marijuana than to synthetic cannabinoids. But it was a big problem a while ago.
Can you say relatively whether marijuana use is any more worse or better than alcohol use in the ER, for example?
In terms of overall numbers, alcohol use is by far much more prevalent, much more damaging, but that also reflects general trends in the public too. More people drink alcohol than smoke marijuana. But I would say that I see much more damage at this point from drunk drivers, from people falling downstairs while intoxicated. So the actual absolute numbers for alcohol is much higher, but it's also the use numbers are much higher in the public. But alcohol is a whole nother topic. It's more culturally acceptable. It's in religious texts that they had alcohol, so it's just a trickier subject, I would say. Not even to mention the whole prohibition and then repealing prohibition. But I would say alcohol use disorder is a real thing. I've seen lives destroyed from it. I've seen young people die from liver failure, horrible deaths. I've seen, innocent people hit by drunk drivers and killed. So I'm not downplaying, I don't downplay the serious effects of alcohol use disorder. I think that just like marijuana, just like tobacco, it can cause harm, but it's harmful, yeah.
Do you see any different effects in the ER based on the strain, like an indica versus a sativa? Does that factor into anything that you see?
No, I think most of the people who come into the ER, I would say, are relatively naive to cannabis, and so they don't know the details of the individual strain. To the point where people know the strain really well, you have to have a really detailed knowledge of marijuana. We actually don't see many of those people, except for the cannabinoid hyperemesis syndrome patients, which I said is relatively rare. But most of the people we see don't know that level of detail. I don't know any studies that have looked at whether one strain causes more intoxication than the other. I know that many people advertise sort of one strain is better for things than the other, but I don't know.
We have room for one more question. All right.
Thank you very much. I'm curious if there are any laws that are being proposed or any advocacy of laws that would be proposed to include dosing so that our Illinois laws would reflect the knowledge that's been gained through previous states' experiences.
Yeah, I don't know of any proposals that are currently in the works. I tried to find information on dosing regulations, but I couldn't find any that reflected sort of the Colorado improvements, like they can't be packaged like candy, they have to clearly demarcate individual doses. I haven't been able to find anything like that, and I haven't yet made it into a dispensary to actually look at the products. It's only January 24th, but that's sort of my next step. I just want to look to see what it actually looks like in Illinois. But the few people who I've emailed about trying to sort of improve these things, sort of standard thing where I just don't get a response.
I made that up. One more to follow up.
This is just a medical comment that although we have, quote, indications for medical marijuana for syndromes, we don't really have pharmaceutical-grade marijuana knowing precise dosing in the U.S., except for one prescription product that you mentioned for some rare pediatric forms of epilepsy. So other than we're just talking to growers or dispensaries saying, well, we're aiming this more for CBD predominant, but with so many compounds, these are not purified medications. So I wanted to make that point and get your comment too, that it's interesting that in California they're putting that on the edible, because I think I believe University of California, San Francisco was going around the street, seeing what's there, trying to identify what compounds are in it, what's the potency.
Yeah. What was the thing about California specifically that they're putting what on the edibles?
I'm sorry, pardon? No, I'm sorry, maybe you mentioned Colorado, that they were labeling the edibles. That's the first I've ever seen of dosing, because most of the time people don't know the dose of what they're getting or the mixture of compounds in the product.
Yeah, so you're right. Colorado is not labeling the mixture of cannabinoids or the percentage of cannabinoids, I would say, but they are measuring THC at least and giving the concentration of THC to say it's 1 serving size. But yeah, I think you're right that medical compounds we don't have good dosing information on, and part of that has been the federal restriction on research for marijuana because it's in the same class as LSD right now and heroin, that there's no medical indication for it and that it's a high potency for abuse medication. And so a lot of professional organizations have been really lobbying the federal government to change the classification to allow more research because we need that in the lab to develop sort of more specific dosing. And right now we just sort of have these broad laws that differ from state to state that just say medical marijuana can be used for these conditions. And then I believe in Illinois it's a very long list. It was too long to put on a slide. But we really don't have precise enough data to say like for MS, for spasticity, you should use this strain, this percent CBD. We just don't have that information.
Thank you, Dr. Howard Kim. Thank you.
Thanks for having me.